Just a quick heads up before we begin. Everything in this episode was accurate when we recorded it, but things move fast in evidence-based medicine. For the most up-to-date and definitive information, then please refer to Red Whale Knowledge. And if you notice anything that might need updating or have any feedback, then we'd love to hear from you. Now, let's get started.
Hello, I'm Ali Smith.
And I'm Nick Kendrew.
We're both part of the Red Whale team.
Come with us as we make your life easier and reignite your passion for primary care.
Welcome to the Getting Your Cosy Jumpers Out of the Loft episode of the Primary Care Pod from Red Whale.
The Primary Care Pod from Red Whale.
You might be staying up to date with your best mate.
Doing your PDPs with your hive of bees.
Or reading a Pearl whilst doing a 12.
We're here for some discerning learning.
Grab a tea, CPD. Enunciate. There we go. I think that works.
Lovely. That was lovely.
Here's what's bubbling up as we dive in search of our pearls this month. Gonorrhea. Recently, the news outlets have been reporting that the UK gonorrhea vaccine has become widely available through sexual health services. So we're here to help you with any consultations that you might have about it.
Emotionally based school avoidance. Depending where in the UK we live and work, we're all at different stages of settling in to the return to school. So we wanted to look at our article on emotionally based school avoidance, previously less helpfully called school refusal, so that we're prepared with key information if questions come our way.
And here's what's bubbling under for next week. Obesity and weight management in pregnancy. NICE produced updated guidance on nutrition and weight management in pregnancy earlier this year, so we're going to share what NICE suggests.
Cognitive behavioural therapy for menopausal symptoms. Hero, villain, or just difficult to access? When NICE updated its menopause guidance in 2024, it recommended cognitive behavioural therapy as one tool to support women experiencing menopausal symptoms. This received a mixed reception in the media. Come back next week as we take a deeper look.
Okay, so back to the top of the list and pearl number 1, and we're talking about gonorrhea. So, Ali, I thought we'd start with a quiz here for a bit of fun to get our brains fired up at the start of the podcast. So are you up for it?
I'm definitely up for it. I mean, I think if I was to go on mastermind, gonorrhea would not be my specialist subject, but I will give it my best go.
Okay, well, that's good. Okay, so here we go, and let's dim the studio lights. Okay, so here's your first question. So these questions are all true or false. And if you're listening at the moment, then you can play along as well. So just shout out your answers. Just be careful while you're doing that. If you're doing it in the gym or on a dog walk, it might be quite weird. But that's all fine. So here we go. Gonorrhea infections have increased by 1/3 in the past decade. True or false?
Gosh, I feel quite under pressure now. Okay, well, I know gonorrhea infections are rising, so I think I'm going to go with true there.
Okay. Is that your final answer?
Yes, that's my final answer.
Okay. Oh, Ali, it's false. So gonorrhea infections have more than doubled in the UK in the past decade, with over 85,000 cases reported in 2023. And that's from the UK HSA GRASP report in 2024.
Oh gosh, so it is on the rise, but faster than I thought. Okay.
Here's another one then. Gonorrhea is the 3rd most common STI. True or false?
I'm pretty sure chlamydia is the most common STI. And then what would be second if gonorrhea was third? I'm not sure. So I'm going to say gonorrhea is the second most common, which makes it's false that it's the third most common. I'm going with false. False, Nick. Final answer.
Okay, that's locked in. And you're right. Gonorrhea is the second most common STI in the UK. It disproportionately affects younger people aged 15 to 24 years, men who have sex with men, people of Black Caribbean ethnicity, and those living in areas of deprivation. And that's from the BASH gonorrhea guideline in 2025. Okay, so question 3. Rates of multi-drug resistance are high in the UK. True or false? And that's obviously in relation to gonorrhea.
I'm not sure about this one. I know there definitely is concern about multi-drug resistance, but I haven't really got a clue about the actual numbers. I hope maybe it's not that high yet, so I'm going to say false.
Is that your final answer?
Yes.
And you're right. So antimicrobial resistance is a significant global concern, but thankfully rates of multi-drug resistance remain low in the UK, with only 6 cases detected since 2015. However, reduced susceptibility to first-line antibiotics is increasing, and resistance to penicillins, tetracyclines and ciprofloxacin is more common. And that's from the UK HSA GRASP report in 2024. And we know cases are rising, so let's not sit on our laurels here. So well done, Ali, for all of those. How did you get on while you were listening? Do text in and let us know. So let's now jump into the Pearl.
Okay, so looking at gonorrhea, the British Association for Sexual Health and HIV, which we abbreviate to BASH, updated its guidance on gonorrhea this year in 2025. And there were changes to the guidance on antibiotic choice, specifically the first-line treatment, and also updated recommendations on testing for pharyngeal gonorrhea in all cases and contacts of urogenital gonorrhea.
Now, how much we get involved in testing and treating gonorrhea will vary, but it's important that we know about the changes so that we can signpost patients to get the help that they need. Now, if we suspect gonorrhea clinically or a patient tests positive on a NAT test, which stands for nucleic acid amplification test, then we should ideally refer to GUM for confirmation and management.
First-line antibiotic management for uncomplicated anogenital and pharyngeal gonorrhea is ceftriaxone 1 gram intramuscularly as a single dose. This means that ciprofloxacin is no longer recommended as the first-line treatment, and that's due to safety concerns.
Okay, so there's a few questions popping up in my head right there. So what if we don't stock that, or my patient is allergic or needle phobic indeed?
Yeah, those are all very valid points. So BASH do give alternative regimes in their guideline, but we would recommend referring to genitourinary medicine if you weren't already thinking that. And of course, we want to make sure that treatment failures are avoided. So the most suitable and effective treatment is the one that's going to be preferable.
Exactly. And following general advice for treatment is important too. And in primary care, we can reinforce this even if we're referring to GUM, such as giving patient information and safe sex advice. For example, we should be recommending abstinence until 7 days after they and their partner or partners have completed treatment.
And regarding the management of contacts, this will most likely and ideally be happening in the sexual health clinic, where they're much better equipped to undertake tests and perform contact tracing. As we mentioned earlier, the updated guidance does state that pharyngeal swabs should now be offered to all sexual contacts as well as the usual testing.
And it's important to know, and I only learned this recently, that the use of doxycycline post-exposure STI prophylaxis, that's DoxyPEP STI prophylaxis, doesn't protect against gonorrhea infection. And so people using these regimes should follow the same guidance as all other contacts.
Yes, that's right. And do have a look at the written article to see which contacts would also be eligible for empirical treatment if that's of interest to you.
Now, vaccination has been discussed recently in the media, with the quoted gonorrhea vaccine being offered through sexual health clinics from August 2025 for eligible groups. So what do we need to know about that, Ali?
Well, firstly, it's worth knowing that there is no licensed vaccine against Neisseria gonorrhoeae.
Okay.
However, Neisseria meningitidis is closely related to Neisseria gonorrhoeae, and the 4C-MenB vaccine, which is currently in use in the UK childhood vaccination programme as Baczero, is the vaccine that's shown real-world effectiveness against gonorrhoea, and it's been shown to reduce infection risk by about 40%. So the JCVI, that's the Joint Committee on Vaccination and Immunisation, has recommended an off-licence use of the 4C-MenB vaccine for at-risk groups through sexual health services.
Okay, and who's eligible then?
So at present, there are 3 eligible groups, and this comes from the Green Book, which is published by the UK Health Security Agency. The first of those 3 groups is gay, bisexual, and other men who have sex with men with a history of any bacterial STI in the past 12 months. And then the next eligible group is gay, bisexual, and other men who have sex with men who have a history of 5 or more sexual partners in the past 3 months. And then finally, our third eligible group is people for whom risk assessment by a sexual health professional indicates similar risk to those in the first 2 groups. And examples of those include sex workers practicing condomless sex and trans women and gender diverse people who were assigned male at birth. And it's worth noting that in those with a current gonorrhoea infection, the vaccine is offered at the same time as treatment of active infection to avoid delay in protection. And people who are vaccinated receive 2 doses at least 4 weeks apart with no maximum time interval between doses.
Okay, great, thank you. And whilst we won't be issuing this in primary care, it's helpful to know about so that we can signpost our eligible patients.
So perhaps a nice little take action point there is to see if this is being offered in your local gum clinic and making sure that your colleagues know about it as well. You could just signpost them to this episode.
So here are our learning points. Gonorrhoea is the second most common STI in the UK, with infections more than doubling in the UK in the past decade.
Ceftriaxone, given intramuscularly, is now the first-line antibiotic treatment.
The 4C-MenB vaccine has been recommended off-licence and eligible groups have been identified. So there we go, a nice quick one to start us off this month. So Ali, how are you doing?
I'm doing good, thank you, Nick. We're actually recording on the very first day back at school for my kids after the summer break. So mixed feelings today. I think the parents listening will probably empathise with me. You know, there's a bit of sadness that those weeks together are over, but also a big sigh of relief that I've got no one in the house sort of telling me they're bored and asking me for a snack every 5 minutes. So, yes.
What about the kids?
Yeah. Well, Nick, whatever you do during this recording, don't ask me for a snack, okay? You're going to have to make it yourself. I'm not doing it for you.
Exactly. I'll do it myself, don't you worry.
Okay, good. How are you, Nick?
I'm all right, thank you. Yes, it's funny. So since my summer holiday, in fact, we spoke about this before I went on for my holiday back in June, and we were talking about how I was going to do those like HIIT classes and stuff and have the resistance bands.
Oh, yeah.
You know, I've managed to keep it up, which is quite exciting. So I've been, and it's really interesting because I was watching Joe Wicks, the UK's PE teacher in lockdown. He did all those videos.
Yes, I'm a fan. Yeah.
And so I had a video that I used. Video makes it sound like we're in 1986, but I had a file that I was using on my iPad.
Sure.
Or tablet, shall we say? And it was a HIIT class, and it was really good. And they said something along the lines of, everybody's got 10 minutes or maybe 20 minutes that they can do a day for their own well-being. And that, for some reason, resonated with me because up until then, I've been thinking, I haven't got time to do this, that, the other. But since then, I've managed to do 3 times a week. I've been doing a 20-minute HIIT class, and I feel so much better for having done it. And in fact, I've done one this morning before recording the podcast. So and I feel on fire. So, but it's really helped. So
that's nice. Yeah.
But it's funny how if somebody just says something that you then think, actually, that now fits into place and it makes sense to me, suddenly it becomes doable. So that's me.
I think I've heard Hussein mention before that concept of exercise snacking. That doesn't always have to be a huge amount of time. You can just do a little bits here and there. Yeah. Exactly.
So there we are. That's what's working for me. So I'm going to try and keep going. Are you a GP trainee or do you know one? We've got some exciting news.
We know that GP trainee years can feel daunting and expensive. So Redwell has joined forces with the MDU to provide a free education package tailored to GP trainees, which has been really popular. Nick, can you tell us about it?
Of course, this is the GP Trainee Essential Support Package, exclusively available to GP-ST MDU members and affiliates. It's worth £165 and is designed to build your knowledge and confidence to help you pass your exams. So what does it include, Fee?
You get access to the whole of Redwell knowledge. That's over 900 written resources to support you during consultations and with exam preparation. Some of you describe it as like having an educational supervisor in your pocket. There's also a digital Top AKT Topics handbook, which contains topics that the RCGP says people find challenging in exams.
You also get access to 4 on-demand exam preparation webinars that demystify workplace-based assessment, AKT, SCA, as well as statistics and data interpretation.
And from August 2025, we'll be sharing a monthly video bite on common primary care presentations to support your learning even more.
So, who's eligible and how do they access it?
This all depends on where you are training. If you're a GP trainee in England, indemnity is provided through your deanery. But in addition to this, you can sign up for free MDU affiliate membership anytime during your training. You will then be able to access the GP Trainee Essential Support Package for free. And if you're a GP trainee in Scotland, Northern Ireland or Wales, you choose and pay for your own indemnity. Therefore, if you choose the MDU as your indemnity provider, then you will gain free access to the GP Trainee Essential Support Package. Just visit themdu.com to find out more. Click Choose to Join MDU and you can see all the options.
Once you're signed up, you'll receive a code from the MDU so that you can access GP Trainee Essentials as a free member benefit. And when you CCT, if you choose to continue with MDU indemnity, then you'll get a free Red Whale course of your choice or a discount on Red Whale Unlimited to support you in your first year of practice. So, if this is of interest to you, then see the link in the show notes for full information and T's and C's, or search Red Whale GP Trainee Essentials to learn more. And now here's Ali with the Red Whale calendar.
So we've got lots of exciting stuff coming up, including our live obesity course presented by Hussein on the 26th of September. We've got a live GP update course online on Saturday, the 27th of September. IO's presenting that one. That's the last GPU course of the current spring-summer season. And then on the 14th of October, a whole new season of GP update launches. So you can access that on demand from the 14th of October. And then on the 16th of October, Kate and Catherine will be presenting a live on-demand GP update course in the studio. Or also on the 16th of October, there's a face-to-face GP update course happening in Manchester presented by Mike and Fiona. So you could book on to that now and come along to Manchester, my part of the world.
So, we've got some interesting topics this month. And here at Red Whale, we want to make your life as a clinician easier.
That's right. The topics we choose to discuss here, we choose them because we hope they're going to make tomorrow easier for you because you were here listening today. So things that were new or recently updated, or things that we all find tricky.
And these are things that you might not hear about anywhere else. So are you ready for our second pearl, Ali?
I certainly am.
Excellent. So this one is emotionally based school avoidance, or EBSA. Now, we used to call this school refusal. Is that right, Ali?
Yes, we did. So we use EBSA now, or emotionally based school avoidance, in preference to the term school refusal, because the emotional bit highlights that the child's non-attendance is due to underlying emotional or mental health or well-being difficulties, rather than framing what's going on as an act of defiance or refusal to attend.
Okay, and why does EBSA matter?
Well, we see associations between EBSA and a number of really significant negative outcomes, including, and this is drawn from a review in BMJ Mental Health from 2024, things like lower educational attainment due to missing lessons. And even when managing to attend school, anxiety associated with EBSA may impair learning in the classroom. We also see increased risk of mental health problems, difficulty with transitions, for example, from primary to secondary school, problems with peers. We see fewer friendships and social withdrawal. It's linked with family conflict and relationship difficulties at home, as well as stress and frustration in parents and carers. I mean, it's worth saying here that that includes financial stress for parents, sometimes because their ability to work is affected. We also see associations with EBSA and risky or criminal behaviour and lower employment prospects as well. So it's really, really serious stuff. And Nick, can you talk to us about what we know about why EBSA happens?
Yes, so EBSA typically arises from a complex interplay between predisposing factors and a precipitating event or change in the child's circumstances. So I'm going to summarise risk factors for school non-attendance, thinking about the child and also the family and school factors. And this comes from School Attendance and Mental Wellbeing, which is from the Anna Freud National Centre for Children and Families in 2024. So if we look first at the child or the young person, so they may have things such as anxiety, depression, or other mental health difficulties. They could also have difficulties managing or regulating their emotions. Trauma and adverse childhood experiences, so ACEs, could also be part of this. They may also have difficulties making or maintaining friendships, or there may be social isolation. There could also be separation anxiety or attachment difficulties with the parent or their carer. Also, they might be having special educational need or disability, or they might be neurodivergent, or they may have low self-confidence or self-esteem. And all of those things are important here. Now, regarding the family or home life, there could be family stress, for example, financial problems, conflict or domestic violence. There could also be changes at home, such as divorce or separation or illness of their parent or carer. Also, they could be a young carer themselves. There could be loss or bereavement. There could be parental mental health difficulties, or there could also be a family history of difficulties at school. And if we look at school itself, then there could be bullying going on. There could be difficult relationships with school staff. There could be lack of provision to meet specific learning or wellbeing needs. There may also be difficulties in particular subjects or physical spaces. There could be demanding or pressurized expectations to achieve, and that could be from the school or from the parents or the caregiver. Or there could be transitions, such as from primary to secondary school. All of that could be a problem as well.
Thanks, Nick. That's really helpful. Yes, and then thinking about other factors that can also influence school attendance. We see this pattern where children who are able to attend the first week of school then seem to be more able to go on to attend regularly. Obviously, there's issues kind of between correlation and causation when we look at that. But what the statistics show are that children who have an unauthorised absence, even for a day in the first week of term, are then at higher risk of persistent absences. So those children have a 25% rate of unauthorised absence compared with only 2% of children who manage to attend every day in the first week of term. So I suppose what we take from that is that those transition times at the start of a new term are really important, and some children really struggle with them, and extra support at that time is really important. We also know that vulnerable children may be at greater risk of EBSA. So from statistics in 2021, we see that about 33% of pupils who are receiving free school meals were persistently absent, compared with only about 20% of pupils who were not receiving free school meals. So that appears to be a factor. Also thinking back to the COVID-19 pandemic, we know that the prolonged school closures then disrupted social routines and peer interactions and heightened feelings of isolation, and that situation contributed to a breakdown in the relationship between families and schools in some circumstances. That's from the 2024 BMJ mental health publication. And then there's also the cost of living crisis, which has created further hurdles to attendance. So things like difficulties affording school uniform or transport to school. So Nick, what support do children in this scenario need?
Well, the varied risk factors and difficulties associated with EBSA mean that most children will need a multi-agency approach that involves education, health, social care and voluntary sectors. Early intervention before EBSA becomes chronic or entrenched is often important, but the lack of services in many areas can be a major barrier to accessing prompt and effective treatment.
Okay, so that multi-agency support, what does it look like? Well, it can look like supporting and educating parents, helping parents to communicate with school and collaboratively find ways to overcome barriers. And also school-based interventions are really important. These include adjustments to the school day and environment to help facilitate a return to school. So this might be things like providing safe spaces in school for the child, temporarily reducing homework or other demands, implementing a flexible phased return to school, offering support for when anxiety is experienced at school, for example, teaching anxiety management or relaxation techniques to the child. Really important one is making sure school are appropriately referring for assessment of special educational needs, addressing peer relationship difficulties or bullying, also really important, and also optimising that home-school communication, which includes the school taking a non-judgmental approach and working in partnership with parents. So that's sort of what the overall approach looks like. But Nick, what can we actually do in primary care?
Well, I think that many of us are going to feel a bit helpless when we see families in this kind of scenario, but actually there's lots that we can do. And we often know families well, and they may turn to us when they have concerns, and that puts us in a unique position to be able to help. And we can help explore factors affecting the child and the family, and also issues at school. So in particular, we have a role in encouraging parents and carers to speak to school staff about any worries that their child may have, enabling them to work together to support the child and improve attendance. Also discussing the health and wellbeing benefits from good school attendance, emphasising the importance of attendance for every child's long-term outcome while continuing to support the child and their family. Identifying any underlying mental health difficulties and offering advice, including signposting to self-help or community support or referral to CAMHS if indicated. Supporting parents and carers, including assessing their mental health needs and offering treatment for those where indicated. Also supporting school attendance, so consider making a practice policy to try and schedule routine appointments outside of school hours to minimise time taken off school. And also making a risk assessment and acting promptly on safeguarding concerns if a child may be at risk of harm. So you've got some information on safeguarding and homeschooling there, haven't you, Ali?
That's right, Nick. And the first thing to say, to be super clear, is that when parents choose to homeschool, so elective homeschooling is absolutely not an inherent safeguarding risk. And in fact, it can be a really effective and positive education strategy for many children. Families choose to home educate for lots of reasons, including the scenario of a child who has previously struggled with EBSA and then there's been a decision to homeschool. And in fact, some families feel that, home educating is the safest and the best option for their child's well-being, as we said, for varied reasons, including around bullying or where the family feel that there isn't an education setting that meets their child's needs. So, this isn't about being anti-homeschooling at all. It's just the safeguarding thing we need to think about is where children are both vulnerable and have risk factors, and they're also homeschooled. They can become hidden from view because they lose those protective factors like regular contact with their teachers and access to free school meals. And that means that safeguarding concerns might be less likely to be recognised. So in primary care, we've got an important role with these kinds of families, and it's helpful for us to explore with families and understand the reasons that they've chosen home education. And then that might guide us in how best to support the mental health and overall well-being of that family. Of course, it's not our role to oversee or evaluate the educational aspects of home education, but for some vulnerable families where that regular contact with teachers isn't there, we might have an extra important role in safeguarding, which could involve liaising with local authorities and social services if we need to.
Okay, so that's all been really helpful. Thank you. But do you have any action points for us, Ali?
Yes, I would say one of the best things you could do if you want to read a bit more about EBSA is have a look at a website which is linked in our Pearl called Not Fine in School. So Not Fine in School has loads of information for both parents and for professionals. So the kind of topics they cover include supporting mental health in children and young people who are absent from school, making sure that absence due to physical or mental illness is correctly recorded by school as an authorised absence, the importance of prompt assessment for special educational needs, our role in supporting action being taken if bullying or other issues are reported. The website mentions that, sometimes issues are beyond bullying. Things like assault and sexual assault can happen in schools. So, how to act if those things are reported to us. There's also the whole issue of EHCPs, education healthcare plans, and educational psychology assessments. So if you want to read about that and supporting families to advocate for accessing those, that's all in this resource as well. Things like supporting the child to have connections with school while they're absent, ongoing homework to be issued from school, that kind of thing. And guidance for us about when to make social services or early help referrals. So it's a really excellent resource, and I would say check that out. That was quite a big take action point, wasn't it?
It
but
was,
it's all there.
but thank you.
So yes, our take home messages then for EBSA. Absence from school is associated with negative outcomes, including lower educational attainment, mental health problems, and family stress or conflict.
We need to take a holistic approach to understanding the causes of EBSA and consider a range of risk factors that may relate to the child, their family, and the school environment.
Our role in primary care includes encouraging families to work collaboratively with school, looking for mental health difficulties and possible neurodivergence, supporting wellbeing in parents and carers, and being alert to safeguarding concerns.
And Ali, on the topic of CAMHS, you've been involved with creating our CAMHS course, haven't you? Can you tell us a bit about that?
Yes, I really do think it's a brilliant course, and it's really helped me, developing the course has helped me with this area that I find so tricky sometimes. It's only 3 hours long, so it's a really manageable length. It's an online course, so worth looking into. If you're interested, we cover just a little rundown of what we cover. It includes assessing children and adolescents and their mental health concerns, understanding the impact of adverse childhood experiences on mental and physical health, which is so important. We look at how you can build your own skills in recognising and managing depression and anxiety in children and young people. We give you some key micro skills to support young people while they wait to be seen by CAMHS, which we know, can often be longer than we would like. There's a lovely section on there on eating disorders, supporting young people with self-harm, looking at suicide risk as well, really useful stuff. And lots of useful stuff on neurodiversity in the CAMHS setting as well. So ADHD, autism and Tourette's as well. So yeah, that's my little plug for the CAMHS course.
Excellent. Thank you very much. And now it's time for some primary care superheroes.
So I would like to take this opportunity to nominate one of my own colleagues, actually, or well, kind of all of my own colleagues. So I work at Firdale Medical Centre in Northwich, and Holly, who works at my practice, has come up with this really fun idea to help us all be a bit more active, where we've called it the Firdale Flame. It's sort of an inflatable Olympic torch, and Holly's planned a route where it's going to go between all of our houses, and we're taking it either by walking or cycling or jogging, or I think there might be some other activities involved, as a way to all get to know each other better and all stay active. So it's made its first couple of journeys now, and I think it stopped for a glass of wine at a couple of people's houses, and it's coming to my house soon. So just a big well done to all of my colleagues, and thanks very much to Holly for organising.
Excellent. What a fabulous idea. Thank you for that. And also a big shout out to the Monday Maidens, who invariably work a duty day on a Monday at Hereford Medical Group and keep each other sane-ish, in brackets, through the year's ups and downs. And that's from Dr. Claire Hollingsworth. So thank you for that as well. Now, if you're hankering after a Redwell Knowledge subscription, then we're offering a 10% discount on Redwell Knowledge for our fabulous Redwell Pod members. And so how do you become a member, I hear you ask? Well, if you're listening to us right now, then you are part of our pod. So hello. Now, all you have to do is go to redwell.co.uk, put Redwell Knowledge in your basket and enter the code RedwellPod to get 10% off. And here's a small print. The discount is only for this product and it won't work on anything else. And please also note that this voucher code is all one word and it's all lowercase, Redwell Pod.
If you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It only takes a few seconds and we would really appreciate it. And if you can spare a little more time, then please leave us a nice review. Because of the way algorithms work, it means that other people just like you can discover us.
And of course, putting algorithms to the side, then there is no greater recommendation than a word of mouth recommendation. So if you've got some value from listening to the podcast today, then don't keep it a secret. Tell everybody that you know who might benefit from listening. All the resources that you need are in the show notes and all the links are in the show description on your preferred podcasting platform.
You can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. And if you want us to see something about the podcast, then please use #RedwellPod.
And the other thing that you can do if you click on the link in the bio is to leave us a voice message telling us about anything that you found helpful or would like us to go over.
You can also email us. Our address is podcast@red-whale.co.uk. And until next time, I'm Ali Smith.
And I'm Nick Kendrew.
Remember to keep Redwell Knowledge open on your desktop at work so we're with you when you need that extra bit of information or reassurance.
Take care and look after yourself. Bye-bye.
Goodbye.